Carefully observe the skin for cyanosis. The best place to ensure that the infant is pink is to look in the mouth. A true pink, the color of a strawberry, is normal, while cyanosis appears more like the deeper red of a raspberry. You already observe the infant's respiratory rate. This is an important component of the cardiac examination as well, because peaceful tachypnea often accompanies heart disease. Palpate the peripheral pulses. This is particularly challenging in squirmy, chubby infants. The brachial artery pulse in the antecubital fossa is easier to feel than the radial pulse at the wrist. It is also important to feel the quality of the femoral pulses to rule out coarctation of the aorta. The femoral pulses lie in the midline just below the inguinal crease, between the iliac crest and the symphysis pubis. Take your time when palpating the femoral pulses. One trick is to flex the infant's thighs. The infant will likely stretch them out a bit and allow you to palpate in the inguinal canal. You should also try to palpate the dorsalis pedis and posterior tibial pulses, although these may be difficult to feel. The point of maximal impulse is often not palpable in infants. Next, place your hand on the chest to feel for thrills, which are quite rare in infants. Auscultate using the diaphragm of your stethoscope in all areas, including the second right interspace, or aortic area, the second left interspace, or pulmonic area, the left lower sternal border, or right ventricular area, and the apex, or left ventricular area. While the specific order is not critical, it is important to auscultate in all areas, listening carefully for S1, S2, S3, or S4, and any murmurs. Now repeat using the bell of your stethoscope. Infants commonly have premature atrial or ventricular beats that sound like skipped beats. These will usually go away when the infant cries and the heart rate increases. If you can auscultate while the infant is very quiet, you should be able to detect the splitting of the second heart sound, or S2. Detecting this split eliminates many serious congenital cardiac defects. Third heart sounds are low-pitched, early diastolic sounds commonly heard in infants. They reflect rapid ventricular filling and not disease. You might even hear a gallop in the presence of a normal rate and rhythm. This is normal in infants. Remember that infants breathe rapidly, so you'll need to mentally subtract the sounds of respiration from the heart sounds. Listen for the intensity of the second heart sounds. Listen for systolic or diastolic murmurs, as well as third heart sounds. Fourth heart sounds are rare in newborns. Listen carefully for heart murmurs in the axillae and also in the back to help you identify pulmonic murmurs.